everyone, and thank you for coming to our presentation on taking control of incontinence. My name is Katie Ouillette-Harrington. I am a doctor of physical therapy, specializing in pelvic health, and I'm also a sexuality counselor and educator. If you have any questions throughout the presentation, there is a Q&A button that you can go into, so your questions will be anonymous and we will be able to answer your questions at the end of the presentation. So feel free to put your questions in there if you have any. So our objectives for this presentation is to understand the anatomy and physiology of the bladder and the pelvic organs. We're going to go over the main types of incontinence as well as the risk factors for those types of incontinence, and then we'll go over familiar treatments, common treatments that we do for incontinence. So a little bit about me, my educational background. I started off my college career at Delta Community College with my associates in applied science as a health fitness specialist, and also got my certified personal training certificate through the NSCA. And then after that, I transferred to Central Michigan University to get my bachelor's in kinesiology, and then stayed there for my doctor of physical therapy program. And then just 2 years ago, I went through the University of Michigan School of Social Work to become a sexuality counselor and educator. And then postgraduate, I've been studying pelvic floor ever since. And then a little bit about my personal background. I live in Midland with my family, with my husband, my 2 stepkids, our 3 dogs, and then we have 2 babies on the way that will be here this summer. I like to stay active. I like to run and lift weights, and then we really like to hike and get out in nature. So at least that's what those pictures are from. So let's hop right into pelvic floor anatomy. So this is the pelvic floor anatomy of a female body. On this first picture on the left, that is if you cut your body in half like hot dog bun style. You took one side off and you're looking in there from the side. So on this front part, we can see your bladder. And then here is your uterus and your vaginal canal. And then this is your rectum. And from here, we can see these little like pinkish, bubbly looking things. That is your pelvic floor muscle. So you can see how it connects from your tailbone and holds up the rectum and around the rectal opening. It comes around the vaginal opening, and some of it does come up the vaginal vault as well. And then it wraps around the bladder, the urethral opening right there, and then connects onto your pubic bone. So it's kind of like a sling. And then the picture on the right, that would be what we're looking at, what the OB is looking at when you get a pelvic exam. So it's kind of looking up towards your head. We can see your sit bones onto the sides here. That's the yellow. And then we can see the urethral opening here. That is the vaginal opening and the rectal opening. We can see how those muscles very nicely wrap around those openings. We can see those muscles off to the side. Our pelvic floor does have 3 layers of muscle, so that is what you're seeing there. And then this back one here is our glute muscle, the big buttocks muscles that it's coming and connecting right into that tailbone and sacrum as well. So if we want to get more of a 3D version here, we can see your 2 hip bones. It stops zoom or blurring me out. Your pubic bone on the front, your sacrum, let's stop doing that, and then your lumbar spine. And so then from there, you can see your bladder, uterus, and then your rectum. They kind of sit one in front of the other. And if we take those out, you can see right into the opening of the pelvis. So it's kind of shaped like a bowl all the way around. So that is our female body pelvic floor. Now for our male body, so this first picture on the left is still cutting our body in half hot dog bun style. We're looking in from the side. We can see the bladder here. The prostate sits below that. Then we have the rectum right behind that. And still you can see this pinkish color down here is the pelvic floor muscles connecting from your tailbone, supporting the rectum, wrapping around the opening, coming up to the pubic bone, and then you can see how it's like a sling that's supporting the bladder. So functions of our pelvic floor. We like to think about it as the 5 S's. Easy to remember that way. The first one is support. So the supporting is acting as a basket to support our pelvic organs. So for female bodies, if you still have your uterus, a bladder, uterus, and your rectum, and for male bodies, it's the bladder and the rectum. And the support muscles there help act against gravity and abdominal pressure to hold those organs up. For sphincter control, those are the muscles that are wrapping around the urethral and rectal openings to prevent leakage. But then those muscles also have to be able to relax to let our urine and fecal matter out, so our pee and poop. Those muscles have to be able to contract to hold it in and then relax to let it out. Stabilization, so you can see how those muscles were attaching to both of our hip bones. Here, our pubic symphysis on the front. And then once you take these ligaments out, you can see how it connects onto the tailbone here. So those muscles work in conjunction or together with our low back muscles, our hip muscles, our core muscles to help stabilize all of our joints around that area. So our sacroiliac or SI joints, our lumbar spine, our hips, our pelvis, pretty much help stabilize that whole girdle. And then we have sexual functions. So when our muscles are working correctly, the way we want them to, the pelvic floor muscles will help with being able to achieve an orgasm and pleasure with sex. On the opposite end, that can cause difficulty and pain with intercourse. So these muscles help achieve erection of a penis to allow for penetration, and dysfunction there can also lead to pain with a penis owner as well, or with them to difficulty maintaining an erection or achieving orgasm if their muscles are either too tight or too weak. And then lastly, the sump pump. So as you can see in this picture off to the left, this is our diaphragm. This is our pelvic floor. Our pelvic floor, you can see, is supporting our pelvic organs. So if this is our diaphragm, this is our pelvic floor. When you breathe in, your diaphragm lowers and flattens. So should your pelvic floor. When you exhale, it comes back up. So that's what that pistoning mechanism is. And that pumping mechanism helps pump blood and lymphatics, or like the fluid in our body, back towards the heart. So the core is a very important part of our pelvic floor. Our pelvic floor functioning, excuse me. So our core consists of 4 different muscles, one of them, being the pelvic floor. So we went over that is the support system that helps connects from your pubic bone to your tailbone. We went over the functions for that, the 5 S's. And then next is your transversus abdominis. So that is the muscle that is pictured to the right of this. So this one here, the transversus abdominis is our deepest core muscle, our deepest abdominal core muscle. And you can see how it's almost like a corset. So it is along the bottom of the edge of the rib here, connects all the way up to our sternum. It wraps around our back and inserts into our back muscles and tissues. It inserts along the edge of the pubic bone here, and then our hip bones. So it is our main core stabilizer for our abdominal muscles, and that works directly with our pelvic floor and co-contracts with it before movement and during movement to help lengthen and stabilize the spine, the pelvis, and the pelvic organs. So that muscle is super important when it comes to pelvic floor function. That is actually probably one of the main muscles that we work during pelvic floor therapy. Our next part of our core is our diaphragm. So that is our breathing muscle that sits below our lungs. And like I said, it lowers and flattens when you breathe in and then elevates when you breathe out. So that diaphragm you can see in this picture to the left, it's almost kind of shaped like an umbrella that's sitting below our lungs. And then lastly is the multifidus. So that is the picture onto the right here. Our multifidus goes along our entire spine. So from the top of our head down to our sacrum, and they're really short, tiny muscles that are connecting to each vertebrae, and they're very deep, but they have a very important job of stabilizing the backside of our core, so our low back. So that can be important for both maintaining continence, but also that will help with low back pain, hip pain. It has a lot of functions. So again, these muscles also contract synergistically before and during movement to lengthen and stabilize the spine, pelvis, and pelvic organs. So it helps us maintain that pressure that can happen inside of our bodies. So how is our core working? So we went over that breathing or that piston system with the diaphragm and the pelvic floor. But when all these muscles are working correctly and synergistically, it helps maintain pressure control inside of our abdomen. So if you think about your whole core as like a pop can, the top of your pop can is your diaphragm. The bottom of the pop can is your pelvic floor. The front is that transversus abdominis, and the back is the multifidi. So if all of these muscles are working correctly, it's like our pop can is closed. The integrity of it is good. You can't really increase the pressure a lot inside. Things are well managed on all sides. If one of these muscles starts to work incorrectly, it's like we're opening that pop can, we now can put a lot of extra pressure inside of that pop can and things can spill out. So that is where that pressure control comes in. So it's important for controlling that intra-abdominal pressure and decreasing pressure on the pelvic floor. So if we have an increase in intra-abdominal pressure with coughing, sneezing, laughing, lifting, exercising, and those muscles aren't working correctly, all the sides of our pop can, that's pressing down onto the pelvic floor, and that's what can lead to the leakage. So an important part of our pelvic floor is our breathing mechanisms. So we're going to go through a quick demo on the most optimal breathing patterns, which is using your diaphragm. If you're sitting up nice and tall, you should put your feet on the floor, put one hand on your chest, and one hand on your belly. First, do a body scan. Make sure all of your muscles are relaxed from head to toe. So making sure you're not crinkling your eyebrows, not squeezing your jaw, shoulders are down and back. Do a little wiggle. Relax those belly muscles, butt muscles, pelvic floor muscles. Make sure you're not squeezing anything. I want you to take a deep breath in to the hand that's on your belly. So think belly first, belly big, chest little, chest last. So take a deep breath in and then out. When you breathe in, the hand that's on your belly should come up first, chest should come up last. So incorrectly, if you breathe in, yeah, my shoulders are kind of going up, my chest is coming out. That's what we don't want to happen. We want our belly to breathe into our belly first, so our belly should come out. And that is on using your diaphragm to breathe optimally. And breathing with your chest can increase anxiety, and anxiety will cause you to breathe with your chest. So it creates this vicious circle. So diaphragmatic breathing helps with optimal pelvic floor functioning like we talked about, but it also helps regulate anxiety. So come on, inner peace, I don't have all day. Just work on 30 seconds of diaphragmatic breathing at a time, and that will actually help regulate that. So proper breathing patterns. Let's go over types of incontinence. So there are a few different types. One of the most common is stress incontinence. So that would be leaking when you cough, sneeze, laugh, exercise, going from sitting to standing, on a walk, on a run. There is urge incontinence. So when you have the urge to pee, you have to get to the bathroom now. So the urge is very strong, or that you're going to leak, or you leak when you have the urge to go to the bathroom, or getting to the bathroom and taking off your clothes, you start to leak. That's urge incontinence. You can have both. That is called mixed incontinence. And we have a few more types. Overflow incontinence. So you might have the urge, strong urge to urinate, but only a little bit comes out. And then you leak urine even though you don't have the urge to go. So that could be that the bladder is filling up too much and your receptors in there aren't communicating properly. And then there's functional incontinence, that where you leak because you can't get to the bathroom on time because it might be hard to walk fast, or you can't unbutton your pants fast enough. Risk factors for leakage or incontinence. Having more than 3 children, and this will be more so with vaginal births compared to C-section. Any abdominal surgeries, because that's going to change the way our canister, our pop can, is working when you cut into those abdominal muscles. So C-sections, even hysterectomies that were removed abdominally, gallbladder surgeries, appendix surgeries, even scopes, even getting those scopes where you have little tiny scars, that's also going to affect the way those muscles fire. Pelvic or abdominal surgeries is on there twice, but any pelvic surgeries, so getting a bladder lift, getting a hysterectomy via vaginal, that will change the way those muscles function as well. Chronic cough, allergies, sneezing or vomiting, because that's increasing intra-abdominal pressure and putting pressure down onto the pelvic floor organs. Aging, so postmenopausal general weakness and bladder changes happen with aging. There are ways that we can combat that with exercise though, so that's a good part. Poor posture or breathing strategies. So if we are rounded forward in our upper back, or if our lumbar spine, let's say, is tilted too far forward or backward, that will change the way that the pelvic floor muscles are sitting. So meaning, if our back's rounded forward, that's going to change the amount of pressure that's coming down to the pelvic floor. It's going to change kind of like our center of gravity. And then if your lumbar spine, which is the lowest part, if that's tilted too far this way or this way, that will change how well the pelvic floor muscles will fire. So that can increase chances of leakage because of pressure. Low back or hip pain. Usually when you have pain, we have weakness in those areas. If you have weakness in those areas, your pelvic floor is not going to fire as well. And unfortunately, having a female body, because we have 3 openings instead of 2, which inherently makes the muscles more susceptible to weakness and dysfunction. So some more risk factors. Certain foods, drinks, and medications can be bladder irritants. So the most common are alcohol, artificial sweeteners, caffeine, carbonated drinks, certain heart and blood pressure medications, sedatives, which are the ones that make you sleepy, and some muscle relaxers. Having constipation, because if you remember back onto this slide, and same thing for the male bodied, how the rectum sits on the bladder and rectum sit kind of right behind or in front of each other. If we're constipated and our rectum is filled with stool, that's going to put pressure onto the bladder. If there's pressure onto the bladder, that can increase your chances of leaking because there's not as much room in the bladder, but it's also going to kind of push the urine out of the bladder. And the other thing with constipation is if you're straining a lot, that will put pressure down onto the other pelvic organs, including the bladder, which can cause a prolapse. An enlarged prostate, because the prostate wraps around the urethral opening, so that will change how urine comes out. It can get trapped in places. Prostate cancer or after a prostate removal, because I will have a slide on that we'll go over next. So we'll talk more on the prostate removal. And then some neurological disorders. So multiple sclerosis, Parkinson's disease, a stroke, or a brain injury, that is going to affect the nerves. The nerves have direct control over the muscles. So if we have dysfunction in the nerves, it's going to directly affect how the muscles are working as well. So after prostate removal, post-prostatectomy, this is a surgery for prostate removal, most often due to cancer. Stress incontinence is the most common issue following surgery. So this can be due to pelvic floor weakness, because the prostate is partly responsible for keeping a male-bodied person continent. So their muscles aren't equipped to be as strong. So when you take that prostate out, They are, you can get core weakness or nerve involvement from the surgery itself, so leading to poor muscle and bladder control, core weakness from the scope incisions, extra pressure down onto the pelvic floor. Pelvic floor can't withstand it because it hasn't been trained to. That increases leakage. So the likeliness increases for post-surgery leakage if there are urinary problems present before surgery. So if there are any people on this call who have had their prostate removed, or if you know someone who's had their prostate removed and they are complaining about leakage, pelvic floor is a definite option for them. So incidence for that ranges from 1 to 40%, 1 to 87%, and 6 to 8%. So when I was trying to find statistics, it was all over the place. But this varies based on the definition of incontinence, and many people don't report that they're even having leakage, so it's hard to get really accurate numbers. But the longer you wait to start therapy or interventions, if incontinence is present, the longer it will take to recover. And that's for everyone, but especially post-surgery. So bodily changes causing dysfunction. So with anatomical, if you have a prolapsed bladder, meaning your bladder has fallen backwards into the vaginal canal a little bit. So if you see down here on this picture, if this bladder is prolapsed, it comes, pushes down into the vaginal wall a little bit. That will increase your chance of leakage. Loss of estrogen. So postmenopausal is the most common one that can cause muscle weakness, pelvic floor or core weakness. So this can be stress-induced postpartum with a vaginal delivery. If you have repetitive lifting, that increases pressure down to the pelvic floor and can stretch out the muscles, or weight gain, which also puts pressure down onto the pelvic floor and stretches out the muscles. So the sphincter injury post-childbirth, again, most often vaginal. The sphincter, remember, are the muscles that wrap around the urethral and rectal openings, so pee and poop doesn't come out when we don't want it to. Those can be injured and tear with vaginal deliveries, which can increase your chance of incontinence. Neurological, so learned bladder habits. So if we are going to the bathroom a lot, just in case, that's going to change how your bladder is communicating with your brain, which can increase your chance of leakage. That can cause hypersensitivity of the bladder or the pelvic floor muscles. And then bladder stretch receptors, for that one, we like to call this nurses or teachers bladder, where you hold your bladder for a very, very, very long time because you don't have time to go. Your bladder can, the receptors inside that tell you, hey, you gotta pee, get stretched out. So then that can increase your chance of incontinence because your bladder's filling up a lot. Or if we have any nerve lengthening or injury with vaginal deliveries, that will directly affect how our muscles are functioning because our nerves. And then chemical, so bladder irritants that we talked about, and also limiting fluid intake can irritate the bladder because the urine is so concentrated, the bladder doesn't like it, it wants to get it out, so you can leak more. So sometimes, actually a lot of times, when people are having leakage, they're like, well, if I drink less water or less liquids, then I won't leak as much, but generally the opposite happens. So you need to make sure you're drinking enough water. So how do we fix incontinence? It depends. So it depends what is causing it. If you have weakness in any pelvic floor, core, or hip muscles, we're going to work on strengthening those. We're going to work on posture correction because we need to make sure we have a good posture so our pelvic floor works the best way it can. Working on our breathing. If you have increased muscle tension, so if you're holding your muscles in a chronic KEGEL and the muscles are always lifted, they are going to become tight, so they don't even have enough room left to kind of lift and help you stay continent, but they're also going to be weak commonly because to keep our muscles strong, they need to go through the range of motion. So if they're too tight, they're not moving, they're going to become weak. So we would work on down training the muscles to get them to relax, so then we can get an adequate lift. We would again work on core strengthening because if our core is stronger, then our pelvic floor can relax a little bit because most often, if we have core weakness, our pelvic floor can try to compensate and become too weak to try and stabilize our canister. And then stress management. because the more stressed we are, generally the more tension we hold in our muscles. So we need to make sure that we are relaxing our muscles and mostly our pelvic floor. And then bladder retraining. So learning and understanding the optimal bladder habits and decreasing irritants will help with that. And actually in the follow-up email, there is a link to a blog post that I wrote that can help you with the bladder retraining. Getting started with that quicker. So we just do a bunch of Kegels, right? Absolutely not. I don't know if any of you watch Schitt's Creek, but David is my absolute. So Kegels are not always the answer. They're not the only tool in our toolbox. So if we need to down train the muscles, let's say your pelvic floor muscles are very tight, like we talked about, and they're upregulated and overused, we need to lengthen those muscles before we strengthen them. So doing like hundreds of Kegels a day is actually not beneficial. And just like we wouldn't do 100 bicep curls a day, 100, 200, 300, whatever, you're not going to do that many Kegels a day. So we don't want to work it too hard. And if we already have a tight pelvic floor, we do not want to do more Kegels. So that's where you might not even need to do a Kegel at all. So if you're someone who has pelvic pain with intercourse, or a really strong like urgency and frequency, you might not need to do Kegels. We might need to down train your muscles. And that's where this next slide comes in. So to Kegel or not to Kegel, if you experience pelvic pain with intercourse or vaginal penetration, urinary urgency and frequency, Kegels may not be appropriate for you to start with. So I got a little ahead of myself and already did this slide. So just like I said, you don't want to do too many Kegels. If you do, you wouldn't do 500 bicep curls a day. So you would do 500 Kegels a day. Because muscles are still muscles. But let's learn how to Kegel properly. So sitting up nice and tall, making sure you're not hunched over, feet are flat on the floor. A couple different cues here because they work differently for everyone. Pretending there is a ball or marble low in your pelvis, like at the vaginal opening, you're going to tighten around that object and lift it up. So it's like you're trying to lift a marble or a ball with your vagina. That's obviously for female bodies. Tighten your muscles like you're trying to hold back gas or not trying to urinate. Another way, you should feel a little bit of lift in those vaginal muscles. Pretend you're tightening your vagina around a tampon, drawing your sit bones towards each other. That's the bony part of your butt. Draw your pubic bone to your tailbone. For penis owners specifically, pretend you're walking into a cold lake. You should not feel, when you do this, your abdomen, your butt muscles, or your inner thigh muscles tightening. You should not feel your pelvis moving. So someone should be able to look at you and not even know that you're doing a Kegel, because you're only using those vaginal muscles. This will be easier lying on your back or your side or on all fours. It is harder in seated and standing because you're lifting against gravity. Babies are giving me hiccups. All right, so working on our transversus abdominis. So remember, that is our deepest abdominal muscle in our front of our canister. So this picture of this person doing it is obviously lying down, but we can do it in seated. So again, sit up nice and tall. We're going to soften our upper belly. And we want to draw in our lower belly just above our pubic bone. So you're kind of tucking your belly button towards your spine. Sometimes it's easier to pair that when you're breathing out. So if you take a deep breath in, breathe out, and then tuck your belly button towards your spine. If your hands are on your belly, you should feel your muscle or your stomach move away from your hand. So you should feel a muscle kind of like tighten and move away, almost like a trampoline. You can also imagine there are wires connecting from the front hip bones, one on each side, and you're trying to tighten the wire. If you say shh, drawing in the lower belly, again, it should move away from your fingers. Another cue is narrowing your waist, or imagine you're putting on a tight pair of jeans. So what you should not feel if your hands are on your belly, you should not feel a muscle like pop out into your hand, or you should not feel your stomach push out. If your hands are on your belly, your stomach you should feel a muscle move down and away from your fingers. So those are with the breathing, the proper Kegels if you need them, and this transversus abdominis belly bracing. Those are great things to get you started of making sure your pelvic floor has the best function. Those are generally beginner exercise we give for I shouldn't say everyone, most people. So what is pelvic floor therapy? So we work on your deficits that may be contributing to your current complaints. So this could include, but is not limited to, abdominal, core, or hip weakness. You could have trigger points or painful areas that are going to affect how your muscles are properly functioning. Muscle lengthening if the muscles are too tight. We want to stabilize our joints, work on pain, and work on bladder retraining. So common diagnoses that are treatable with physical therapy: urinary and bowel incontinence, urinary urgency, fecal incontinence is on there again. We can also work with constipation, any type of pelvic pain. So if you're familiar with these terms, someone has told you that you have them: levator ani syndrome, dyspareunia, which is pain with intercourse, vaginismus, which is tightening of the pelvic floor muscles, or vulvodynia, which is usually painful on like the vulva or the outside. Pelvic organ prolapse, so any type of prolapse, uterine, bladder, rectal. Pre and postpartum pain, abdominal pain and dysfunction, tailbone pain, diastasis recti, which is the separation of those abdominal muscles, pudendal neuralgia, pediatric bowel and bladder function. What's not on here that would go along with pelvic and abdominal pain is like endometriosis, sometimes PCOS. So we always do an individualized treatment approach. So pelvic floor dysfunction can be due to several different causes that we went over in that last slide. The pelvic floor can be weak or it can be guarded. So as pelvic floor therapists, we assess your entire system. We evaluate your strength, your function, your coordination of the abdominal, pelvic floor, low back, and hip muscles. If you're experiencing any of these symptoms that we're about to go through, definitely get a referral from your provider. That could be your primary care provider, a urologist, a colorectal doctor, or your OB gynecologist or midwife. So if you feel any heaviness or bulging in the pelvic floor area, leaking urine, or inability to control bowel movements, that gap or separation along the midline of your abdominal wall, so that's that diastasis or diastasis, worsening pelvic, low back or hip pain or abdominal pain when other medical issues have been ruled out, or pain with intercourse. So what we see clinically, most patients will see improvement in strength after 6 to 8 weeks. That is if you're doing your home exercise program. We almost always give exercises or something for you to do at home because we generally see you once a week or once every 2 to 3 weeks. So we can see an improvement in control of urge incontinence or strong urinary urgency. That's generally seen within 3 to 6 weeks once we work on that bladder retraining. And like the bottom says, consistency is key. Just like you brush your teeth in between going to the dentist, you need to do your exercises in between going to see your therapist, because muscles need to be loaded and worked to get better. Other treatment options besides pelvic floor therapy, there are medications. Most common when it comes to this are given for an overactive bladder. Those often do have side effects though, so dry mouth and eyes and constipation. A pessary, so if you have a prolapse and that is your main cause of your symptom, this is an option to help support the bladder. So it kind of goes up into the vaginal canal, pushes the bladder back a little bit so it's not falling into the vaginal canal and it's better in line. So this is very beneficial to try before surgery or as an adjunct to exercise. They come in many shapes and sizes, and your OB-GYN can help with fitting those, or a urologist. There are surgical options. So severe cases that don't improve with conservative measures, generally will get referred back to see if there's anything that can be done surgically. However, this may be helpful short term, but long-term benefits are still questionable, and because we still need to address the deficits. So if someone has, let's say, a prolapse that is causing their leakage, they go straight away to surgery and they don't do pelvic floor afterwards, you're not fixing the issue that likely led to the prolapse. So if your bladder is prolapsed, you're not strengthening the core, you're not strengthening the pelvic floor or the hips, you're still going to have an increase in abdominal pressure coming down. There's a very good chance that 10 years down the road, your bladder is prolapsed again. So we need to make sure we are maintaining those strength of those muscles. And you may have restrictions that follow is another thing that comes with surgery. So lifting restrictions and such. For penis owners that are having leakage, a penile clamp could be beneficial. This does not replace pelvic floor physical therapy, but it does close off the urethra to help prevent leakage in the interim. But it is for short-term use only, like I said. It does not replace strengthening the muscles. Our take-home message. I know that it can seem embarrassing to talk about these things, or you might have the notion that, oh, I've had babies or I'm aging, so it's normal to have this leakage. It is common, but it does not mean you have to live with it. So talking with your doctor about urinary incontinence to get treatment options, overcoming those barriers to treatment. So embarrassment, assumptions that incontinence is normal, fear of surgery, media influence, or, oh, I've done Kegels for years. I've had people that have come in and said that, and they're not even using the correct muscles. So making sure you're doing them correctly, but also if they're even right for you. And with the embarrassment, like I said, it's a lot. It's common to have incontinence post delivery, post surgeries, and with age, but that does not mean you have to live with it. So be willing to dispel those myths about incontinence, understand that conservative treatments are available and effective, and consider physical therapy for pelvic floor rehab. It's something that we see every single day. So we have 16 locations for Renew Physical Therapy. We have 4 locations that specifically treat pelvic health. So I am in Bay City on the west side. I'm also in Midland. And then we have a few other girls that are in Carroll, and then we have 2 in Saginaw. So thank you all for your time. May your coffee, your pelvic floor, intuition, and self-appreciation be strong. And anyone who registered today will receive an email with my contact info. So if you have any questions, you'll be able to email me directly. And I love questions and love to help people out. So don't be embarrassed to email me. There's no such thing as TMI when it comes to pelvic floor physical therapy. We talk about pee and poop and sex all day, so nothing really phases us. If you did register, you will also receive a recording of this video and some helpful tips of these takeaways, and that will include, like I said, the link to that blog.
Thank you, Dr. Katie. I was thinking of questions the whole time, but anytime I thought of a question, you answered it for us. So
okay, perfect.
I didn't see any come in. So it looks like you did a wonderful, comprehensive job, and we appreciate you.
Yes, for sure.
Thanks for joining us, everybody. Look for that follow-up email. And thanks again to Dr. Katie.
Thank you.